Okay, I think we better make a start and conclude our competitive discussion about where it's sunniest, although I'll lift my laptop and say you can certainly see sort of sunshine behind me coming through the window into the Eric Wilkes room here at SHAR. So welcome to today's mini masterclass. I do believe this is masterclass number 20. Correct me if I'm wrong, Andy. So a small milestone in the history of the masterclass series. For those of you who haven't been along before, just so you know how Blackboard Collaborate kind of works, if you haven't used Blackboard Collaborate before, haven't been to a masterclass before, the main things you need to know are about the chat box, because that's what we mostly use for questions and general communicating. So if you click on the little purple tab in the bottom right hand corner of your screen, this white panel will appear, and from there you can access the text chat box. So if you click on that, you just type into the box in the bottom right hand corner of the screen that appears, hit enter, and we'll be able to see. And in terms of asking questions today, what we'd like you to do is, as you probably heard us discussing earlier on, if you want to ask a question, you can type your question in at any time during the session, but we will come to them at the end, and we'll try and get through as many as we can. Sometimes we're able to get through all of them, sometimes there's just too many and we can't quite get to everyone, but we'll do our best. It's fine also to make comments or to sort of chat between yourselves a little bit if you want to in the chat box, but if you're asking a question that you want us to try and cover at the end, can you just put Q in front of it, just the letter Q, so we know that this is definitely a question for the presenter and not just obviously sort of comment or conversation between you all in the chat box. If you want to ask a question in person, you can do. You can switch on your microphone and your webcam using the little icons at the bottom. If they're not active at the moment, we certainly will make them active when we come to the question session. So you can do that if you want to. Otherwise, just put your questions in the chat box. And if you are having any issues with sort of audio or video, the settings, the little cog in the bottom right hand corner, if you tap on that, you will see exactly what you can see on the screenshot, the option to change your audio and video settings, so you can just check whether it's, you know, the right sort of camera microphone have been chosen to be used in this Blackboard Collaborate session. John is obviously a professor here at SHAR and therefore is involved in teaching on a range of our programs, including our MSc in Health Economics and Decision Modelling. So that's a full-time or part-time on-campus program in Health Economics and Decision Modelling. It's quite a unique course because of the decision modelling kind of element to it. Some of you may be aware also of our MPH, which we're very well known for, our Masters in Public Health program. And if you're interested in either of those programs or any of the other ones that we run here in SHAR, our next online open day for campus programs is coming up on the 13th of April, and I'll put that link in the chat in a moment once John starts his presentation. We have these online open days. They're just an hour. They're hosted in Blackboard Collaborate, just the same thing as we have here today, and you just get to find a bit more about our online programs, but also ask questions of the various program leaders. We also have some short courses coming up in SHAR. We run all of our short courses online now since the pandemic, because we found that generally it's far more convenient and accessible to people to do our courses online. So again, I'll put the link in the chat box, but all of those all those courses you can see listed on the slide are upcoming ones on a range of different topics related to the kind of research expertise in SHAR. Just a reminder about our Communicable Research podcast that you can access on Spotify, Apple Podcasts, and the Android podcast app, or pretty much any other podcasting app you can think of. The latest episode is with Dr. Laura Fenton, and it's about the decline in youth drinking. She's joined by Professor John Holmes and Dr. Abigail Stevely. It's a really, really interesting episode about the decline in youth drinking, but lots of these kind of factors associated with that, and lots of other behaviours that seem to be declining among young people, and the potential reasons for that. The next couple of mini masterclasses we've got coming up in the next couple of months are first of all with Dr. Annette Hayward, who's going to be talking about green social prescribing to prevent and tackle mental ill health. And then we have Dr. Lindsey Blank, who's going to be talking about interventions to reduce the public health burden of gambling related harms. So if you want to book for either of those, again, I think Andy will probably put the link in the chat, but do sign up for either of those if you're interested. But today we're joined by Professor John Brazier, who's going to be talking about extending the QALY beyond health, the EQ-HWB, health and wellbeing. There is so much I could have said about John in my little introduction, but I'll try and keep it fairly short. So John's a professor of health economics here at SHAR in the Health Economics and Decision Science section. He was the first director of the Economic Evaluation Policy Research Unit, known as EPRU. And he's currently an NHEHR senior investigator. He has more than 25 years of experience in conducting economic evaluations of healthcare interventions for policymakers and has published over 200 peer-reviewed papers. His particular interests are in the area of measurement and valuation of health for economic evaluation, and he's best known for his work in developing a preference-based measure of health for the SF36, SF6D. I'm going to hand over to John now to take over, but I'll just swap over the slides quickly, John, so that you don't have to. How long have you been in SHAR now, John, in years? I've just had my 19th anniversary of years in SHAR.
I've been at the university for longer than SHAR's existed, so shall we say over 30 years?
Right, okay, you win. Although I think Andy's ahead of me, he's like 1 year ahead now, or 2, something like that. Okay, over to you, John.
That's great. Thanks very much, Claire. Lovely to see you all on this fine sunny afternoon. Yeah, and I should add, as Director of Innovation in SHAR, that we do a lot of work, provide a lot of work, advice and consultancy to public and private sector and the third sector. And I think somebody will be putting something in the chat around our IKT inquiries. So if you want to find out any more about what we can do, then please follow that link. Great, so no further ado, I'll begin this masterclass where I'm going to be presenting the work that's arisen from extending the QALY beyond health, or the E-QALY project, as we call it, and in particular, the development of the EQ-HWB, which stands for Health and Wellbeing, which is a new genomic measure. Before I do that, I just wanted to say that though the PI for this project, when it started, I became Dean of SHAR and stepped back a bit really, and Clara Mercury and Tessa Peasgood stepped up and have effectively led the project. So all credit to them really for the work that has happened over the last few years on this project. But any miscommunication of that project obviously is entirely my doing. So just in terms of what I'm going to be talking about, I'm going to be saying a little bit about the motivation for the E-QALY project, say a little bit about some of the theory. I'm going to give an overview of the development of the measure so you can get an idea of the sort of rigor and the thoroughness of the work that's gone into developing this new measure. I'll say a little bit about future plans and hopefully there'll be time for discussion. And I think as indicated, if any questions arise during the presentation, please put them in the chat and hopefully there'll be time at the end for me to address them. And if Clara's in the audience and is feeling up for it, she's welcome as well, of course, to answer the questions in the chat. Okay, I've got a slightly strange thing that's got in the way there. Not quite sure why. I realise many of you will have a health economics background, so please bear with me. I just felt that it was important for those who don't, just to give the bigger context for why we developed this measure. So essentially the basic problem is that there aren't enough resources to meet all our needs or wants, particularly in healthcare. So this effectively means that we have to make choices about what we provide and what we don't provide, because obviously providing one thing, one service, means that we have fewer resources to provide other services. And so we have this sort of choice, this problem of how we make those decisions about what is funded. And economic evaluation is a sort of broad range of techniques that seek to identify, measure and value and compare the costs and consequences of alternative uses of those resources. to inform decisions in healthcare, social care, or indeed across other sectors of the economy and government. Now, in healthcare, a widely used sort of economic evaluation technique is called cost utility analysis, where we effectively compare alternative uses of resources in terms of the cost per QALY that we get from spending resources on this service or that service. And obviously the core part of this is the quality adjusted life year. And the QALY, or quality adjusted life year, provides us effectively with a kind of a currency that we can use to value the outcomes of different interventions, different treatments, and then we can look at the cost of producing those QALYs and make some decision about whether perhaps some interventions provide QALYs at a lower cost, and hence we can provide more QALYs than other things. But the QALY itself is a measure that effectively combines the length of life with the quality of life. And this simple sort of diagram here sort of is just a way of illustrating it. So on the horizontal axis, we have time measured in years. And on the horizontal axis, we have quality of life or health, where full health is given a score of 1, death or states as bad as being dead are given a value of 0, and it is possible to have states, negative valued states as well. And when we tot up the number of QALYs that this health profile has, we simply multiply the duration with the quality of life of that period. So for example, in this case, we have 4 times 1, 4 years at 1, 5 years at 0.7, and 5 years at 0.3, and then we add up those multiples to end up with a value of 9. So this means that this profile that lasts for 14 years is equivalent to 9 years in full health. That's effectively what this does. So it means that we can value any kind of profile, whatever shape it may be. It may go up, may go down, or whatever over time. Now, probably the oldest and perhaps best known example of this is was published in the mid-80s by Alan Williams in the British Medical Journal, looking at the cost effectiveness of coronary artery bypass grafting for severe angina. And you can see here how we've got we've plotted 2 kind of profiles. One is with the old medical management. According to this is obviously highly stylized. You live for 5 years and your quality of life steadily deteriorates over that period. If you have surgery, then you live for longer. You live for 11 years and in better quality of life over those years. And essentially the number of QALYs generated by medical management and by surgery is the area under the curve. So it's quite a simple sort of calculation, given that we have life years on the horizontal axis. And when we're trying to look at what the QALY gain is from surgery in this case, we're looking at that hashed area, which is the difference between profile A for CABG and profile B for medical management. So that's the idea of the QALY. And obviously the key thing here is, in terms of what we're talking about today, is where we get that value on the horizontal axis for health. So the best known sort of instrument, or one of the most widely used instruments for doing this, is called the EQ-HWB, which I'm guessing many of you have come across. And the EQ-HWB essentially is a simple questionnaire that can be completed by patients or indeed by anybody. And it's a simple way of describing your health across 5 domains: mobility, self-care, usual activities, pain and discomfort, anxiety and depression. And for each of these domains, you have 5 levels, from basically no problem to unable to do or very severe, depending on the domain. So we have a sort of 5 by 5 description, really, of somebody's health. And this actually describes in all 3,125 health states. So a lot of health states. This is the 5L version. There is a 3L version, a 3-level one that's still used. It's still used by NICE at the moment, although they are planning on shifting to the 5L in the near future. And this comes with a score, a way of scoring it. So for each one of those 3,125 health states, we have a score on this 0 to 1 anchored scale. So if somebody fills that in, we're able to assign a value to them. And then in the context of a trial or perhaps a non-intervention study, we can actually look at the way in which these scores change over time and actually estimate or calculate QALYs for those individuals. So all well and good. But the challenge is, and I can't quite work out why that why that thing keeps coming in to the left-hand side. I'm sorry about that. So what's the motivation here? Essentially, the QALY, which has its own issues, of course, but essentially most QALYs, when they're calculated in healthcare, tend to use a measure like the EQ-HWB, which, as you would have seen, is very focused on health and particularly on physical health. And so the problem with this, the challenge with this, is that it may well miss important consequences for quality of life, particularly those perhaps associated with long-term health conditions where we're not necessarily in the business of curing them. It's more about managing them, but definitely in social care and indeed informal carers. And I think an important point to make here is that this distinction between healthcare and social care in particular is somewhat artificial. From the point of view of a service user, they have needs, and whether they're met by the NHS or the local authority or whatever, it's the meeting of their needs in the sense that the NHS provides care. And so this distinction is artificial. And when you're trying to understand the overall impact of services being provided to somebody, then being able to, at the moment at least, it's very difficult if all we're looking at is the health aspect and not these broader aspects that we might be interested related to things like somebody's relationships, autonomy, and so on. And the other key part to this is the informal carer, because obviously informal care is a very big part of the health system, the social care system in many ways, and this provision of care by informal carers has an impact on their health and their quality of life. And that's also something that's important to bear in mind when we're trying to understand the impact of interventions. Now, of course, there are measures for measuring things across these different groups. We have EQ-HWB, for example, in health. We have ASCOT for social care, and there is indeed a number of measures for the carer. But of course, using different measures across these different groups raises all sorts of problems of comparability, how you aggregate across them, and how you get an overall picture, really, of the impact that you're having. So this was a key motivator, really, for developing a new measure that was broader than the current health-based measures. And then the other sort of aspect of motivation, which is important, is that a better description, a description that more accurately reflects the way somebody's health condition or their social care needs impacts on their lives, the more accurate the values we'll get then for calculating our QALYs. So, for example, in this case, we've got an EQ-HWB description, a health state, an EQ-HWB health state. And what we do to get our values for that state is effectively ask members of the public to value that state on some kind of scale. Now, I've got a simple ruler there, but the methods for eliciting these values are rather more complex than that, but nonetheless the principle is much the same. We're asking members of the public to imagine that health state and provide us with a value. Now, to do that, essentially there are two stages. Milad Karimi undertook a study some time ago where he essentially did qualitative work asking people what they thought about when they were doing these kinds of valuations. And what he found was that many people said that actually they'd take the health state but then they imagine how that's going to impact on their quality of life in terms of these sort of higher level things such as enjoyment, dignity, personal relationships, independence, and so on. Then having made that judgment about how these domains are going to be impacted, they then apply value. And what we have then is a sort of, if you like, is two aspects to the decision, to the process. We have two stages. One is the technical judgment, which is how's the health state impact on these higher level domains. And then we have the value judgment of looking at the impact of those in terms of providing some sort of overall value or assessment. Now, what Milad found was that when you then actually looked at populations who are in these health states and how those health states actually impacted upon these higher level domains, we found that people systematically make mistakes. And in particular, they tend to, for example, overestimate the impact of mobility compared to depression on these higher aspects of life. So this might lead us to think, well, why don't we drop health entirely and instead look at these well-being domains, these high-level well-being domains, and actually describe those when we ask people to do the valuation, because that will get us closer to what we want. So in other words, why not just use well-being instead of health? And indeed, this motivated the Medical Research Council when they put out their call, which was entitled Beyond the QALY. They were originally imagining that we would develop a well-being equivalent of the QALY, of the health-related QALY. But well-being has its problems, and one is, although broadly we might say that well-being is how good an individual's life is, or overall how well an individual's life is going, there are different views on what this is, the different accounts of well-being. So we have hedonism, which is very much focused on happiness, I suppose, and avoidance of displeasure. Then we have preference satisfaction, much loved of economists, which is if somebody chooses something, it means that that thing they've chosen must give them a higher level of well-being they didn't choose. Then we have subjective well-being, which is rather broader than hedonism in the sense it may include enjoyment and happiness, but tends to include a lot of other things around perhaps relationships, control, and so on. But of course, the problem here is that we're getting, it's called subjective, so there are all sorts of problems of interpersonal comparability and so on. And then we have more objective lists, which some philosophers like, which can be very based around a sort of basket of goods that we think everybody should have, but it can include rights and so on and so forth. But here we have the problem of deciding what's in that objective list, and they tend to be, if you like, decided upon by experts. They don't have to be, but that's often the way. So with these concerns around well-being, Tessa Peasgood led a study where members of NICE, the NHS, and other sort of social care decision makers were asked what they thought about well-being and what role it should play. And essentially what was found was that there was a range of opinion, with some policymakers really wanting, particularly in the health technology assessment arena, wanting very much to stick with health. But many did accept that this was too narrow in many cases, particularly, as I say, for longer term conditions, and did see a role for well-being as an addition to health. Some did go the whole way and say that actually they would like to see well-being. But actually what we sort of gleaned from this was that actually what we're interested in is, in a sense, some combination of health and well-being domains in a new measure. So in terms of developing this new instrument, we were interested in a measure that reflected the impact of health and social care interventions on physical and mental health. We still want health, obviously, but also those broader aspects of quality of life that I mentioned. And a key part of this, as you would expect, is that we were interested in things that were judged to be important by the users of services and informal carers. So we wanted to cover all aspects of life that they felt were affected by either their health conditions, their healthcare treatments, their management of their condition, disabilities, social care needs and use, and the experience of the carer. So a pretty broad pretty broad remit. But at the same time, we still wanted to have a measure that was both a longer term comprehensive measure, because obviously we're potentially talking about a lot of domains here, but also we wanted one that we could reduce down so that we could obtain a preference-based index, and this requires members of the public to do evaluation work. So we needed a shorter version in order to do that, and I'll explain a bit more about that in a bit. And we wanted a measure that could be easily used in clinical trials, routine surveys, etc., and ideally internationally, since many studies these days are international. So an important component of the E-QALY project was the fact that it was international. It did start in the UK, and the original proposal was written in response to a call from the UK Medical Research Council. But it became evident fairly early on that we needed more support, really, to pull this off. And it also became evident that really we wanted it to be international to a degree from the start, because obviously there has been a tendency in the past to develop measures in one country and then look to transfer them, whereas we wanted to have a significant sort of international aspect to the development of the measure. So there were 6 countries in all, including Argentina, Australia, China, Germany, and the US, and they were all recruited through the Euroqol Research Foundation, who actually contributed an equivalent amount of money to the MRC in what was an MRC industrial collaboration. And indeed, the Euroqol group have continued to invest in the measure. And we also had some support from the local clerk, the local NHR clerk. Another key important part of this study is the fact that there were a number of governance and consultation groups, which I'll say a bit more about in due course, because obviously we wanted significant stakeholder input, both policymakers, but also the public. And so we constructed a number of groups to help ensure that we had that. So in terms of the different stages of the project, and the ones in green, I'm glad to say we're pretty well finished. So we started with the conceptual side, looking at the domains that we wanted in the measure based on a literature review, which I'll describe in a bit. We obviously needed to generate a list of candidate items and then put them through their paces in terms of face validation and psychometrics. And the evidence from these 2 stages informed the final item selection, which involved substantial consultation. And lastly, we've been undertaking a valuation feasibility study in the UK. So a key part of all this has been stakeholder involvement. And we've done this, achieved this in a number of ways. So we had a patient and public involvement engagement group in the UK who were involved, were consulted with at all stages in the project, as well as in the item selection, including the conceptual model and so on. So they're involved throughout the project. We had a large international advisory group made up of academics, HTA agency staff, health and social care commissioners, and so on. And also we ran workshops with NICE staff, and indeed we have 3 members of staff at NICE who were part of the project team and were co-apps. We also had a steering group, and we had, as I mentioned, 2 substantive consultations towards the end to inform the final selection. So where do we start? Well, we needed some sort of conceptual model to start things off, and to do this we took a model of health developed by Wilson and Cleary in the 90s, where basically they said essentially we can see this as starting from biological and physiological variables, including, you know, your cells, your body organs, the basic stuff really, and we're interested in looking at how the sort of symptoms or impairments that might arise from those biological and physiological variables And in turn, we're interested in looking at the impact that they have, particularly on functioning. And then lastly, we're asking here people to report how this impacts on their health and the health-related quality of life. Now, we took this model and expanded it to include aspects of social care and caring, including from the condition stage, although obviously it's slightly different. But then we're looking at how these things impact on symptoms and impairment, and base it on people's circumstances. And then obviously we've slightly expanded as well the domains that we're covering in terms of social connections, feelings and identity and so on. And then obviously self-report, because at the end of the day, we want what is largely a self-reported measure. Obviously, this is a simple conceptual model. There's a lot of complexity surrounding it, particularly important of somebody's environment, their expectations, people adapt and so on. So there are those issues, and also it's not unidirectional at all, but it gave us a starting point really for the first key stage of the project, which was trying to work out the domains. So stage one was identifying the domains of the measure, and the aim here was to identify the impact on quality of life and well-being of health conditions, social care and interventions in health, social care and indeed public health, obviously based crucially on the voice of the service users, patients and social care users, and also informal carers. Now, we didn't do our own primary research to do this. We could have spent our resources on that, but felt that the resources were far better spent on tapping into the vast qualitative literature that is out there that already does this, that has already looked at this. So we undertook a targeted, transparent review of qualitative literature that covered a broad range of health conditions, social care users and carers, and the ways in which their circumstances and conditions impacted on their life. But we also looked at the qualitative work underpinning a number of key measures in the field. So in the end, we looked at 42 reviews, 24 primary studies to provide us with the data to inform our conceptual model. So the preliminary sort of set of domains and subdomains that we came up with, you can see on the right, we've got sets of subdomains. So for example, sadness, hopelessness, worry, vulnerability and anger in one color and so on. And you can see how they sort of broadly fall into sort of higher level domains. But you can see how already it's quite a lot broader than what we tend to focus on. We tend to focus on activity, physical sensations and so on. But obviously this is taking us in way beyond that, looking at aspects of relationships and autonomy and so on. So the next stage of the enterprise was to generate items to cover that space, to cover all those subdomains. And to do this, we drew on the terminology, the terms and so on that we used in the qualitative review. We also looked at existing measures and item banks and started off with a lot of items, as you can see, over 600 items. And indeed, where there were no existing items, we added even more items into the pool. And we put these items through a set of sort of agreed criteria to provide an initial selection to get us down to a reasonable number to then take forward to the phase validation. And obviously the challenges were to make sure we had items that would work in a generic context, that weren't too specific to a particular condition. And also we wanted items that convey the information that we needed people to know, but not providing too much. Obviously the preference solicitation is something which we need to think about down the line, where we need fairly simple statements. But we wanted statements that were clear, straightforward, avoided double negatives, didn't make judgments about people's lifestyle, and all these sorts of things. All these issues were taken account of in the criteria we used to make the initial item selection. So having got our 100 or so items, candidate items, we then went forward to the next stage, where essentially we undertook qualitative interviews with samples of patients, informal carers and social care users across the 6 countries, the results of which were used to inform further selection and also in some cases refine items for the psychometric survey. And participants were presented with a sample of items, usually within a set of domains. They were asked to look at a sample of items, they were asked for their response, their thoughts, their understanding of them, and so on. And obviously this process involved translating it into 2 languages. Involved translating it into 3 languages, I should say, and also looking at a range of different sort of cultural contexts. So this provided a lot of information for us as well about cultural relevance. So having gone through this, we were able to eliminate quite a lot of items, modify some, and add a couple of, some more items to fill in some spaces. So then we moved with 60, I think it was 64 items to the psychometric survey, and this was undertaken in the UK as well as the other 5 countries. And in the UK, we recruited some 2,000 people online and through NHS trusts and primary care. And again, obviously, we're looking for a spread across patients, social care users and carers. These items were subjected to a full psychometric testing using known group differences. We also undertook factor analysis to check the dimensional structure and also item response theory to understand better the items. And essentially we found that we could discriminate between known groups for health conditions, but less so for carers. We had essentially well-functioning response categories for each of the items, but there was some evidence of differential item functioning. And the dimensionality was confirmed, except there were some issues in China, particularly around the emotional items. So then we undertook 2 rounds of consultation. Both essentially we approached our advisory group and the Euroqol group and other international stakeholders. We presented a summary of the face validity and psychometric evidence and essentially asked them to select their preferred item, 1 for each of the subdomains. All countries and then all the country teams then recommended a final version of the long measure based on this consultation plus the public involvement group, and we finally reached on a 25 item scale with 1 item for each subdomain with a couple of extras, and this process also involved some combining of closely related items. And the result of this was the 25 item EQ-HWB. I should say that this is the draft that came out of that work. It's since been substantially refined and improved in terms of its format by the Euroqol version management committee. But this is just to show you a bit about what it will look like. And obviously I've tried to highlight the items that cover things like vision, hearing, mobility, daily activities, self-care and so forth. But we also have control or coping, so autonomy. We have aspects around cognition. We have a range of items covering feelings, also a range of items covering relationships like loneliness, support and so on, and obviously some items around pain, discomfort, sleep and fatigue. And these items, some of the items we ask about degree of difficulty, and some of the items we ask about frequency. So having come up with the 25 item, the larger, more comprehensive version, if you like, of the HWB, we then sought to reduce it down to a smaller classifier, which we can then go out to ask members of the public to value. So the second consultation was much the same as the first, except this time we're asking people out of the 25 to choose between 7 and 10 for the classifier, bearing in mind not just the evidence, but also what they felt was important for decision making. And this resulted in a final selection of 9 items for the classifier, which we call the EQ-HWB S for short form. which in this example is able to all get on one page. So again, you've got a couple of difficulty items, you've got a severity item, and then you've got some frequency items. And the dimensions covered, which I've already highlighted, you can see here each item covering a different dimension. Just to sort of highlight how this differs, particularly from EQ-HWB, you can see that there's a lot of overlap. It covers mobility, it covers usual activities through the daily activity item, it obviously covers pain, anxiety and depression. But there's some important differences, one of which is separating out anxiety and depression, because it's felt that they have very different consequences and will be valued differently by people. Depression tends to get valued more heavily than anxiety. But also we've got these additional items now. We've got control, we've got fatigue, we've got the cognition items, and of course loneliness for relationships. So it's covering a significantly broader space than the EQ-HWB. So the final part has been the valuation study, and this valuation, so having constructed our 9-item instrument with 5 levels each, we decided that we simply didn't have the resources to do a full valuation survey, a full valuation of this larger scale. And instead what we've done is to undertake a feasibility study, because obviously we've now got a pretty large descriptive system certainly compared to EQ-HWB. And also we've got this mix of health and well-being. And so we really wanted to see whether, using, if you like, fairly standard methods, whether this presented any problems with the larger classifier. Sorry, Barbie, by classifier, what I mean is a shorter version of the measure, rather like the EQ-HWB, where you have 5 dimensions and the 5 levels for each dimension. In this case, we've got a classifier which has 9 dimensions, and each dimension has 5 levels. By classifier, I mean that by taking different combinations, you can effectively classify somebody into a health state. Okay, and I think with the EQ-HWB, there's 3,125 potential states, whereas with the EQ-HWB, it's a lot more than that. I can't do the maths just yet. So essentially, we asked a sample of the general population to value a small sample of the states defined by this EQ-HWB short form, using time trade-off, which is a fairly standard valuation technique, and also using discrete choice experiments. And I'll say a little bit more about each of those in due course. We had about 500 members of the public, of the general public, who recruited in a variety of ways, and we used a version of an existing tool, if you like, which is a sort of computer-assisted interview approach using video. So the interviewers were interviewing members of the public using video conferencing, and that's partly, of course, a consequence of the pandemic. There was a second valuation study, which I hadn't got time to go into now, which is where we're asking some members of the public to deliberate on the values. So for the time trade-off, essentially we're asking people to trade off length of life and quality of life, and we ask questions a bit like this. So if you take the blue box describes a health state, which is described by the classifier, taking 1 level from each of the 9 dimensions. And we say to people, imagine you're going to live in for 10 years. So that's life B. And then compare that to life A, where you're actually in full health and full quality of life for 10 years. Now, in this case, most people would choose A. Of course you would. And then there's a process of iteration whereby we reduce the number of years in full health, carry on reducing it until people reach a point where life A is equivalent to life B to them. So it might be, say, at 5 years, they may say 5 years in full health is equivalent to 10 years in the blue state, in which case you'd say the value of that state is 0.5. It is rather more complicated for states worse than death, but again, given the time, I can't go into that. But all this is written up elsewhere. And then we had the discrete choice experiment task, where we simply asked people to say take 2 two states defined by the HWB, and just simply say which state do they prefer. And in this particular example, we've highlighted where the differences are between the states. So this is the discrete choice experiment task, and people did a number of these pairwise choices as well as a part of the survey. So just to give you an idea, these are just fairly a simple presentation of the results. I know Clara is busily working writing up these results, but essentially what this shows is for each of the 9 domains of the HWB short form, you can see the decrements, if you like, associated with them. So in this case, this is just, obviously there are 5 level domains, and we're just looking at 2 of them here. We're looking at level 5 and level 3. Level 5 is the most severe domain, and level 3 is the medium one. If you take mobility, if you're at level 3 of mobility, this amounts to a decrement or disutility of just over 0.05. So you take that off somebody's score when you're calculating it. Obviously, if you look at level 5, you can see that it's actually minus 0.2, so a much bigger one. And then you can see how the decrements vary across the domain, pain having by far the largest. Pain, essentially level 5 of pain is you're in severe pain all the time, so it's not surprising that that has such a high weight. But what these results show that yes, physical activity is proven to be important for the general population, but these other things like loneliness and so on and control are still important and are still significant. So there's ongoing work. I won't go into any of this in great detail now. I think the main things is there's further work testing the items. There's further work looking at the valuation, and the Euroqol Research Foundation is working on a source version which is consistent and simplified, and also has sort of smoothed out some of the sort of ambiguities. And there is now an experimental version of this instrument available for methodological work, but you have to go to the Euroqol Research Foundation site if you want to use it in a method study, and there's some sort of discussions to be had. But the hope is that over the next year or so, it will move to a beta status where it will become much more widely available for use in studies. And there's a set of papers in Valuing Health, and I'll ask Andy to send you round this list of papers so you can follow up the links in your own time, and so on. Now, I won't say much more now, just to say that we've developed this new generic measure that goes beyond conventional measures of health to include aspects of well-being that's relevant to patients, social care users and carers, using sort of rigorous methods and so forth in the context of an international study. And yeah, that's all I had to say. Thank you very much.
Okay, thanks for that, John. We already have quite a few questions, not surprisingly. I'm not sure whether Sue's one got covered earlier. Sue asked earlier on, how were the people selected for the survey? Can you give a little more info about how inequalities were addressed, etc.?
Yes, well, there's 2. Obviously, there's the face validation and the psychometric survey. In both cases, we tended to sort of in the UK, we did recruit through the NHS and through primary care, and we tried our best to get a good range of people in terms of age and gender and so forth. We can't make any guarantees, Stu, about the inequality side. Obviously for the online, we're very much more dependent then on the panels themselves. In the papers, we do set out a lot more about the background characteristics of the individuals. We did get reasonably representative samples from what we can see, but obviously we can't guarantee that we got through to all groups.
Okay. Next question. You mentioned there were some problems in China in relation to emotional items. Could you expand on that a bit? Is it to do with the cultural context?
Yes, we think it is. Our Chinese colleagues working on this, or Chinese-speaking colleagues, Nan Luo particularly, essentially in the factor analysis, you basically try and understand what the dimensionality is of the items, and the items tend to sort of group, if you like, in factors. And whilst there is reasonable consistency across the other 5 countries, China did stand out slightly different. And it was that I'm being quite loose here about emotional items, the feelings items didn't fall into the same categories, and in fact tended to form one overall factor. I don't think we've quite got to the bottom of why that's the case. But it was, it's just an important finding. And I think ideally we'd be doing a lot more work, something I should say, a lot more work on this measure in other countries, in other cultures, because obviously this is an important thing to understand.
Okay, next question. Marissa asks, what are the results for impact assessment of social interventions? Is it sensible and how is it measured?
What are the results for impact assessment? Well, I think an instrument like this could help undertake an impact assessment for social interventions, in the sense that it's more comprehensive than a lot of measures that are currently used. So it may have a role in that. Obviously, there's a lot more to impact assessment. There's different kinds of impact assessments for different purposes. But I think what we're hoping is we have developed a measure which, in a sense, anybody can fill in. It's not like it's focused on particular diseases, conditions, or people. So I'm hoping that it would have a role where there's resourcing, obviously, to administer an instrument or make an instrument like this available for people to complete. We're hoping that it would have a role.
Okay, next question. Tim asks, what has been the budget for this impressive work?
Not enough. Quite a big budget in the end, Tim. It's hard to gauge. The overall original grant was in the order of 850,000, something like that. That included all the international work and so on. And obviously there's been some further spending since then, but it is a significant amount of money. And that's why in the end, it was seen as an industrial collaboration seemed to be the best way, because MRC wasn't willing to pay that much. So that's in part why we went to the Euroqol group. But obviously going to the Euroqol group has brought so many other benefits. I'm just really, really glad we did that.
Okay, Rebecca asks, what informed your decision to use time trade-off and discrete choice experiment valuation methods? And kind of as a sub-part of that, Tim asked, for the discrete choice experiments, did you use Paprika?
No, we haven't used Paprika, and I'm sure at some point somebody will, Tim. No, we essentially took the Euroqol group's own, what they call valuation technology, VT, because the purpose of this was not to get too wrapped up in precisely which method, but more to see whether some of the existing widely used methods, how well they work with a larger, more complicated descriptive system as the one that we've formed. So that's why we chose TTO and DCE, because we had the Euroqol technology, which is well known, well used, and there's a lot of experience of using it around the world. But we are now doing further work, and we are looking at more complicated discrete choice modeling, and perhaps even going beyond the 9 items to looking at a lot more of the items of the 25 together in a more complex DC design. And we've got a PhD student, Lindsey Blank, looking at that. And we're also looking at deliberative methods, and in particular, there's some work that's been asking members of the public through NICE to ask us what they think about the methods we've used and what they think about the results. And then thirdly, we're also looking at a technique based on multi-criteria decision analysis, which has been developed from pieces of work by Nancy Devlin and others, by a PhD student, Paul Schneider, who's looking at, and it's called online patient utility functions, which again is slightly different from TTO and DC. So we're not personally wedded to any valuation method. We're more interested in what the implications are when you move to, as I say, a bigger descriptive system like this.
Okay, I think we've got 2 questions that again kind of link to each other. We've got one question talking about how do the advantages of the new methods outweigh the old one, and then a question from Dahlia saying, do you think this is now ready to replace EQ-HWB as the basis of QALY calculation in the UK?
Okay, yes, at the moment at least, the Euroqol group is sticking with time trade-off with DC sort of alongside it, and sometimes these two data sources are combined in hybrid models, and I know Clara's been looking at some hybrid models with that data. And the DCE, you can do other DCEs which actually include time or duration, so effectively it becomes a DCE that's like a time trade-off, but it's just the way you sample states for the comparisons is different. So that's still the sort of the mainstream methodology, but I think there is interest obviously in new methods. Whether the new version of DCE takes over from time trade-off at some point in the future, I really don't know. In terms of Dahlia's question, I think the way we see it is it's very much a complement to EQ-5D. So if you're still basically primarily concerned with health, and many agencies are, like NICE for example, then EQ-5D is there, and it's still going to be, I suspect, the workhorse for QALY calculations for years to come. I think what our measure does, the EQ-HWB, is that it provides a complement. So if you're interested in broader impacts, if you're evaluating programs where these the well-being aspects are rather more important, then I think this measure does provide a useful alternative to people in that sort of situation. But one of the things we will be doing in the future is looking at how the new HWB compares with EQ-5 and other instruments to better understand when it may be more helpful.
Okay, thanks for that. And we've probably just got time for one more, in which case we have a question from Barry who says, what's the level of reception from HTA bodies like NICE to this new instrument, given their preference over EQ-5D?
Yeah, well, I think it's ongoing, Barris. I mean, we had three members of staff from NICE who were involved in the project, I think because they were interested, not because it indicated NICE's support, in a sense. What it indicated was their interest in the work. Because you've got to remember that NICE has responsibilities for more than just technology assessment. It's also responsible for social care, public health, and so on. So I don't know. I think it's watch this space, really. I mean, I think NICE at the moment is still wedded to EQ-5. I think that's definitely true. So I can't see any likely big changes on the horizon. But I think over time, as people come to better understand this measure, maybe there may be more acceptance of it as well in certain situations.
Okay, I think we're going to have to call it a day there because we've run out of time, but we will take a note of the remaining questions. There were an awful lot of questions today. Thank you so much, everyone, for all of them. It's been fantastic to have so much interest in this session. Like I say, I think this is the most questions we've ever had by a long way. But thanks, everyone, for joining us today, and hopefully we'll see some of you in a few weeks for Dr. Annette Hayward's talk.